Hey guys, this is going to be just the audio for the testicular torsion PowerPoint, so you don't need to be looking at me, just have my voice on while you're going through it. If you guys have any questions, please just give me a call or text me, whatever you need, and we'll go through it, okay? So we're looking at just the title page, testicular torsion. Slide 2, moving on. What is your first question? 17-year-old male presents to your clinic with testicular pain. What is your first question? What time did it start? Every time. What time did it start? Should be. If your nurse says this patient's having testicular pain, your first question should always be, when did it start? Because depending on when it started might be kind of how you're going to progress with the management of testicular pain. Okay. So what is a testicular torsion? It occurs when the testes twist around the spermatic cord, limiting both venous and arterial flow to the testicle. This can be spontaneous or it can be anatomical. We'll talk about that here. So what's the big deal? It's a urologic emergency, okay? Time is testicle. So whenever we think about blood flow, we think time is heart in a heart attack. We think time is brain in a stroke, right? So always be thinking time is testicle. You have, depending on the research, 6 to 12 hours to save the testicles. Ideally, you would want to get this in under 6. But if you have somebody who comes into your clinic and they say, I started having testicular pain in the night, and they're not really sure, always err on the side of caution and be overcautious rather than undercautious. Because remember, the worst thing is that you send them emergently to the ER for an ultrasound of their testicle, and it's not testicular torsion, whereas the alternative would be testicular death, infertility. They could get very sick from necrotic testes if it's been, if you miss something. Okay. Moving on, clinical pearls. Next slide, slide 5. If your ultrasound says good flow, an area of reperfusion, what does that tell you? That it was at one point not perfusing, okay? So if you have a testicular ultrasound that says reperfusion, those are signs that at one point in time it wasn't perfusing and now it is. Well, here's the deal. Testicles can tors and untors and retors, and so it's important that you read the entire ultrasound correctly so you're not missing anything. Anytime somebody comes in with abdominal pain and they are a male, you do a testicular exam, because a lot of times we think it's abdomen, and so we work up the abdomen and the abdomen comes back normal, and we never check the testicles, and he was having referred pain from the testicles to the abdomen. So always do a testicular exam. If you say, I'd like to check your testicles, and they say no thanks, then that's fine. You can document patient declined testicular exam. That covers you. At least you tried, okay? Next slide, slide 6. Who can get a testicular torsion? Anybody with testicles, okay? Typically after physical activity or some sort of testicular trauma. Could be light, could be blunt. 65% of cases are occurring between the ages 12 and 18 years of age. This can occur in utero during the descent of the testicle. And the most common deformity is the bell clapper deformity. And I'm fairly certain I have a picture of that here in, well, no, I don't. I'm sorry, I thought I did. But essentially, the bell clapper deformity is when the testicle is not secured to the scrotal wall, and so it kind of hangs there like a bell. If you can kind of picture a bell and the centerpiece of the bell that makes the noise when it clunks against the inside, that's kind of what's happening to the testicle. It just bounces off the scrotal wall because it's not well adhered, and anytime it bounces, you have risk for twisting and torsing and blood flow issues. So there can be deformities that are congenital that put you at risk for increased testicular torsion. So something to be aware of. Okay. The next slide, slide 7. Most males, the testes is attached to the scrotum. Some males have testes that do not attach, and they swing freely like a bell. Okay. Slide 8, clinical presentation. They have severe testicular pain, severe abdominal pain, nausea and vomiting. Pediatric patients may awaken with pain due to nocturnal stimulation. So just always err on the side of caution. Abdominal pain, sometimes these sometimes these testicular torsions almost look like a kidney stone, where they are so severely tender, they're just vomiting, they're having pain, it's all referred, they look very miserable. So like I said, do testicular exams, okay? Physical exam findings, you'll have testicular shortening, testicular swelling, redness, tenderness, absence of a cremasteric reflex, so a negative cremasteric reflex, almost always unilaterally and most commonly on the left, as the left is usually somewhat lower than the right anatomically, and so that's why the left one tends to tors a little bit more frequently than the right one does, but it can also be on the right side, okay? What do? You send for a scrotal ultrasound immediately. If you're at a clinic, send them to the ER, call them, give them a report, let them know your concerns so they can notify the ultrasound department and get the patient straight to ultrasound. If you're in an acute care setting while the patient's in ultrasound, and if you highly suspect that this patient has a torsion, get the urologist on the phone because time is testicle. So while they're in ultrasound, let them know what you've got. Like, hey, I've got this kid. He was just playing soccer with some friends. He got kicked in the scrotum by another soccer player, and he's in severe amount of pain. I've got no reflex. It's incredibly tender. The testicle's shorter. I've got him in ultrasound right now, but I would really like to get you involved. And they appreciate that because that's a surgical emergency, and so they like to have that on their radar early on. Okay. Is every testicular pain a torsion? Nope. Probably done 2,000 ultrasounds of the testes since I've been a nurse practitioner, and I think I've had maybe 3 testicular torsions. So the most common diagnosis you'll find is epididymitis, sometimes orchitis, sometimes they'll not have anything wrong, or maybe even like a varicocele, which is kind of like a varicose vein in the testicle. You'll find those, and those can sometimes be tender if they're irritated. Your differentials, epididymitis. This is slide 12, guys. So what are your differentials? Epididymitis is a swelling of the epididymis. Inguinal hernia. The intestines actually do go into the scrotal sac, so you'll find that the scrotum is larger significantly. So that's when you want to do your hernia check. Sometimes that's not reducible though. Sometimes you'll have that hernia into the scrotal sac and it's not reducible. So if that's the case, then you need to send them to the hospital, because an irreducible hernia could mean that it's strangulated, incarcerated, it's lacking blood flow. That patient's likely not going to be able to have a bowel movement with a bunch of intestines in his scrotum, especially with severe pain. Okay. Testicular mass, such as cancer, varicocele, that's your varicose vein in your testicle. Fournier's gangrene. This is a necrotizing infection, so be sure you're checking underneath the scrotum if they're having scrotal pain, because that's where you're going to see that gangrenous, exudative, purulent infection. It's very common in diabetics, so be sure you're looking there. And then a hydrocele. This is just fluid buildup. Sometimes they're big, sometimes they can be the size of cantaloupes, and sometimes you can hardly feel them. It just kind of depends on the size. They don't generally do anything with hydroceles unless they're affecting blood flow, or they're incredibly tender for the patient, or they're so large that they can't zip their pants or get comfortable. So epididymitis is located on the posterior aspect of the testicle. If under the age of 35 or they participate in high-risk sexual behavior, you need to be checking for STDs. You don't necessarily need to treat them, but you do need to be checking for them. Always check a UA with a reflex culture, because often that's negative if there is no urinary tract symptoms. So just always check that just to be sure. Slide 14, epididymitis treatment. You suspect STDs or high-risk sexual behavior, you give the you're treating for gonorrhea, chlamydia, 250 milligrams of IM Rocephin, and doxycycline 100 milligrams twice daily for 7 days. So that's treating your, I'm sorry, that this should also say that you're adding in some azithromycin, a gram of azithromycin with the Rocephin. But the doxycycline, if you have gonorrhea is becoming pretty resistant to Rocephin, and azithromycin only covers like 2% of the gonorrhea. So the doxycycline is more of a coverage for resistant. And when you think about where this STD is located, it's kind of more in the it's not really upper urinary tract, but it's not just in the bladder, you're talking about in the epididymis. So you need that doxycycline to kind of penetrate any kind of resistant gonorrhea because, again, you don't want to cause any kind of infertility or significant scrotal infections. These things can progress up to pyelonephritis, they can progress into the prostate, so be sure you're covering. If they're over the age of 35, they have low risk factors for STDs, Levaquin 500 for 10 days is appropriate. If they practice anal intercourse, you're looking at different bugs, okay? 250 milligrams IM, Rocephin, and Levaquin 500 milligrams daily for 10 days. So that is all we're going into references right now, but the key for this is time is testicle. Your gold standard test for your testicular torsion is an ultrasound of the scrotal contents. An abdomen, a CT abdomen and pelvis does not make me feel warm and fuzzy that they have good blood flow in their testicles. So please get the ultrasound and prioritize it. You know, what's more time sensitive? Acute appendicitis or testicular torsion? It's a testicular torsion. So if you're not sure, do the ultrasound first. Ultrasound's okay, take a deep breath, send it for CT, rule out the appendix, okay? So be sure if it's on your differential that you are not with any kind of window and that you're not concerned with any of that, okay? If you have somebody come into your primary care office and they say, I've had testicular pain for, 12 days, you can do an ultrasound from the office. You don't need to send them to the emergency department. Testicular torsion should still be on your differentials, but it's probably lower because they've made it 12 days with the potential of a testicular torsion. So you're probably more along the lines of epididymitis or a hydrocele or varicocele. So you can do that from your office, but just be sure that you're asking them how long because it's very key in your history. Awesome job. Good job, guys. I'll see you Wednesday.